Right, beta. So after the infiltrating astrocytoma, now comes the localized astrocytoma, not very diffuse, and it is said to be the pilocytic astrocytoma. It is grade 1, WHO grade 1 WHO grade 1 astrocytoma, right? What does this grade 1 means? It means it is low grade tumor. What does the low grade tumor means? That it is very well differentiated with very low mitotic activity. How can you distinguish this localized tumor from other diffusely infiltrating tumors? एक तो इसकी अपीयरेंस बड़ी डिफरेंट होती है उससे, और the relatively benign behavior of this tumor. This is very much benign, localized to a particular site compared to the previous ones. The previous ones were very much diffusely infiltrating, right? Mostly the children and young adults. Yeah, this is the age group where people develop this tumor, and in what parts of the brain from where it appears, especially the cerebellum में से खास करके ये originate होता है, and it may also appear in the floor and walls of the third ventricle, optic nerve, and occasionally ऊपर cerebral hemisphere. So most common site is the cerebellum. इसके अलावा थर्ड वेंट्रिकल के रूफ में से फ्लोर में से और वॉल्स में से, ऑप्टिक नर्व और ओकेशनली सेरिब्रल हेमीस्फीयर्स में से, ठीक है, काफ़ी लोकलाइज ट्यूमर होता है. The histologic separation of the pilocytic astrocytoma from other astrocytoma is supported by rarity of the TP53 mutations. The TP53 mutations are common in other astrocytoma, but there is a rarity of the TP53 mutations in the pilocytic astrocytoma. So this can be a very important distinguishing point, histological separating point. The pilocytic astrocytoma that occur in patients with the neurofibromatosis disease type 1, they show the functional loss of the neurofibromin protein. In most of the cases, there is the association between the neurofibromatosis disease type 1 and the pilocytic astrocytoma. Most of the people who suffer from this disease, neurofibromatosis type 1, they do develop this tumor, pilocytic astrocytoma, and in association between these two diseases, the individual shows loss of neurofibromin protein. So if I'm suffering from this disease, I develop this tumor, and if you come to see the levels of this protein in my body, you will see this protein is very much decreased, right? Now, what are the underlying mutations that are responsible for the development of this tumor? TP53 तो बड़ी रेयर है, नहीं होती पायलोसिटिक एस्ट्रोसाइटोमा में. तो कौन सी म्यूटेशंस होती हैं वो मैं आपको बताता हूँ. ब्राफ सिग्नलिंग पाथवे के अंदर there are two types of alterations in the BRAF signaling pathway which are responsible for the pilocytic astrocytoma. So what two types of alterations that are found in the pilocytic astrocytoma in BRAF? One is the translocation in the BRAF gene. Number two is the activating point mutations in the BRAF gene, right? Keeping it simple, right? So what are the mutations that are responsible for pilocytic astrocytoma? ब्राफ सिग्नलिंग पाथवे में दो तरह की अल्टरेशंस. नंबर वन, ट्रांसलोकेशंस या पॉइंट म्यूटेशन. इफ़ यू डोंट वांट टू कीप इट कॉम्प्लिकेटेड, जस्ट सिंपली राइट लाइक दिस. ब्राफ सिग्नलिंग पाथवे जो होता है उसके अंदर अल्टरेशंस आ जाती हैं, या ट्रांसलोकेशंस होती हैं या पॉइंट म्यूटेशंस होती हैं, एक्टिवेटिंग पॉइंट म्यूटेशन. दिस is the underlying mutation responsible for pilocytic astrocytoma. Pilocytic astrocytoma is a very slow growing tumor, and the treatment is by the resection alone, surgical resection of the tumor, right? Okay, so yeah, it's easy now. So let's now talk about the morphology part of this pilocytic astrocytoma. So far, what did you understand, beta? The underlying mutation you understand, right? And the age group, the site of the origin, and association with the neurofibromatosis type 1 disease. Easy now? Okay. What is the morphology of this pilocytic astrocytoma? Just a second. Yeah. The morphology part of this pilocytic astrocytoma, the tumor. Okay. if you look to this tumor grossly with your eyes or radiologically on CT or MRI, there is a very well demarcated cystic appearance of the tumor compared to the previous variety that was very much infiltrative. You cannot exactly locate the boundaries of the tumor. I'm talking about the previous variety. Infiltrating variety में क्या था? The tumor was very much diffuse, starting from here right over there, but still you cannot draw the boundary because from here the tumor also goes there. But in this variety, pilocytic astrocytoma, it is very well demarcated in this, like this, in this particular region. This very well demarcated cystic appearance of the tumor is there, right? Or CT MRI पे there are contrast enhancing mural nodules, kind of like this. काफ़ी well demarcated tumor होता है तो mural nodules के जैसी appearance आती है, contrast enhancing appearance आती है, ठीक है? The invasion is very much limited brain invasion because it is not infiltrating variety. And this tumor has got biphasic structure. This is the very important point that is differentiating this tumor from other varieties. Biphasic structure which is alternating. Biphasic structure of the pilocytic astrocytoma means some areas of this tumor are like loose microcystic areas and some areas are compact and densely fibrillar areas. So if this is the well demarcated contrast enhancing pilocytic astrocytoma with very good looking boundaries, you will see some areas alternating with different areas. This is one area of the tumor and this is another area of the tumor, so both are alternating. In this part of the tumor, this is the loose microcystic area, and this part is the compact, very much compact, densely compact fibrillar area, right? So there is a difference. So this is tumor एक ही है लेकिन अंदर alternating प्रॉपर्टीज़ हैं, जिसको बाइफेसिक स्ट्रक्चर कहते हैं, सिर्फ पाइलोसिटिक एस्ट्रोसाइटोमा में ही मिलेगा, कहीं और नहीं मिलेगा। ठीक हो गया जी, चलें ओके। इसके अलावा ट्यूमर सेल्स की बात करें, थोड़ा अंदर जाएं इसके माइक्रोस्कोपी के लिए, अगर इसको देखें, ये तो ग्रॉस पार्ट हो गया ना, ये तो ग्रॉस पार्ट हो गया। अब माइक्रोस्कोपिक पार्ट, इफ़ यू टेक वन ट्यूमर सेल आउट देन यू विल कम टू सी द ट्यूमर सेल इज़ बाइपोलर with long hair-like processes which are containing JAFAP, right? Which are containing JAFAP, and the long hair-like processes give this part dense fibrillary meshwork बनाता है. Just a second, I'll make it easy. It is easy, but okay. If I take this one tumor cell out, one tumor cell is like bipolar, like this. Can you see in center there is a cell body and lots of processes from this side, lots of processes from this side. So tumor cells are bipolar cells with long hair-like processes, right? And the processes contain a protein called JAFAP. The processes are JAFAP positive, and these are the processes which actually give the appearance, that is the dense fibrillary meshwork. Okay. So I hope it is clear to you. ग्रॉसली कैसा अपीयर होता है? वेल डिमार्केटेड, काफ़ी सिस्टिक सी अपीयरेंस होती है, कंट्रास्ट इन्हांसिंग लेजन होता है, काफ़ी लिमिटेड ब्रेन के अंदर इन्वेजन करता है। देखिए ज़्यादा आगे पीछे नहीं जा रहा। बाइफेसिक इसकी प्रॉपर्टी होती है। इन सम एरियाज इट इज़ वेरी मच लूज, इन सम एरियाज विच इज़ वेरी मच डेंस। जहाँ पे ये डेंस है वहाँ पे ये फिब्रिलरी मेशवर्क मौजूद होता है जो कि इसको डेंस अपीयरेंस देता है, फिब्रिलरी मेशवर्क की। ट्यूमर सेल्स बाइपोलर होते हैं, ठीक है। From both the ends there are lots of hair-like processes coming out which are JAFAP positive. Okay, इस तरीके से. Okay, what are the other properties of this pilocytic astrocytoma? Number one is the presence of the rosenthal fibers, and number two is the presence of the mulberry-like inclusions, right? What are the rosenthal fibers that you will see in this tumor? Rosenthal fibers are nothing but the eosinophilic cork-screw-shaped inclusions present in the tumor. So these are the rosenthal fibers, and the mulberry-like inclusions, these are the eosinophilic granular bodies, not the cork-screw-shaped inclusions. Mulberry-like inclusions are the granular bodies. Remember the difference. They are more granular, they are more cork-screw-shaped. Rosenthal fibers and the mulberry-like inclusions. You have to keep the difference in the mind, right? Unlike diffuse variety of the astrocytoma, presence of microvascular proliferation or necrosis doesn't imply the bad prognosis. You remember in case of the infiltrating diffuse astrocytoma, previously I told you there is the microvascular proliferation due to the release of VEGF. VEGF के रिलीज होने की वजह से there is the microvascular proliferation and the necrosis. But in this case, there is also the microvascular proliferation in this variety as well, but it does not imply bad prognosis. ठीक है बच्चों, तो अब जरा नेक्स्ट पेज पे शिफ्ट होते हैं. राइट, ओके जी. So that was all about the what variety? Pilocytic astrocytoma. अब कुछ और टाइप्स हैं थोड़ी सी एस्ट्रोसाइटोमा की, या एस्ट्रोसाइटोमा की कुछ और टाइप्स हैं. उसके बाद हम एस्ट्रोसाइटोमा से कम्प्लीटली फ्री हो जाएंगे. फिर बेटा हम चलेंगे दूसरे ग्लायल सेल पे, ओलिगोडेंड्रोसाइट पे. ठीक है बच्चों, उसको जरा डिस्कस करते हैं. राइट बेटा, आफ्टर द पाइलोसिटिक एस्ट्रोसाइटोमा एंड एट वेरी फर्स्ट द डिफ्यूज इन्फिल्ट्रेटिंग एस्ट्रोसाइटोमा, देयर आर सम अदर वराइटीज ऑफ द एस्ट्रोसाइटोमा. You will surely like this as well. So at number 3 is the pleomorphic xanthoastrocytoma. Why not to compare this with the previous variety we just did, that is the pilocytic astrocytoma. Pilocytic astrocytoma is a nice little baby. It's a really good tumor. It arises from the cerebellum most commonly. But this pleomorphic xanthoastrocytoma arises from the temporal lobe of the cerebral hemisphere. And the age group is same. Mostly there is a history of the seizures. Patient आता है आपके पास, सीजर्स की हिस्ट्री होती है और इस ट्यूमर प्रेजेंटेशन के साथ आता है. ठीक है, चिल्ड्रन, यंग एडल्ट्स, this is the age group where this tumor develops. And the tumor consists of, what about the histopathology of the tumor? You will come to see if this is, let's suppose, the temporal lobe of the tumor. This is, let's suppose, the temporal lobe of the tumor. So in this temporal lobe, if this is the temporal lobe of the brain, and this is the tumor present in the temporal lobe. Okay, and in this tumor you will see on the histopathology there is the presence of the cells, obviously because it is astrocytoma, so it must be composed of the astrocytes. But the astrocytes, don't forget, the astrocytes are very much, occasionally, but very much bizarre in pattern, sometimes filled with the lipids. So if you look into this tumor, right, which is present in the temporal lobe, this tumor is composed of the astrocytes, and astrocytes are occasionally, but they are very much bizarre in pattern, right? And the astrocytes are filled with the lipids, okay. And this tumor, which is actually present in this temporal lobe of the brain, how good looking this tumor is. This tumor composed of the astrocytes are bizarre in pattern, thus the astrocytes are lipid filled. This tumor, no doubt it is a glioma composed of the astrocyte, but you will be very much shocked to know, it's really mesmerizing. I mean, it shows the neuronal plus glial, both markers. I don't know why neuronal markers, and even it is not mentioned, but at least you have to keep in your mind that this tumor shows both neuronal and the glial markers. Here it is written. ठीक है, उसके बाद the tumor cells show the nuclear atypia, that is the feature of the high grade astrocytoma. हमने क्या किया, इसके ट्यूमर में से ट्यूमर सेल निकाला, and we saw that there is there is a nuclear atypia. What does this nuclear atypia means? साइटोप्लाज्म और न्यूक्लियस के रेशो का बराबर ना होना, न्यूक्लियस के अंदर जो है क्रोमेटिन मटेरियल का डेंस होना, न्यूक्लियोलस का प्रोमिनेंट होना, ये न्यूक्लियर एटिपिया इसी को कहते हैं ना, न्यूक्लियस का बड़ा एटिपिकल सा होना. और ये हाई ग्रेड एस्ट्रोसाइटोमा की ही क्वालिटीज़ होती हैं, ग्रेड 4 ग्रेड 3 एस्ट्रोसाइटोमा की. ओके, So how will you then, okay, if this is showing nuclear atypia, and you must be thinking because it is showing the nuclear atypia, it must be a high grade astrocytoma, then how will you distinguish this tumor from actual high grade astrocytoma, which is the, if you remember, glioblastoma. If you remember from the previous videos, it is high grade astrocytoma. Then how will you differentiate between the high grade astrocytoma, that is the glioblastoma, from this high grade astrocytoma? By the presence of these structures in the pleomorphic xanthoastrocytoma. Number one, the abundant reticulin deposits in this tumor. Number two, the chronic inflammatory cell infiltrates the lymphocytes, especially in this tumor, and the absence of the necrosis and the mitotic activity in this tumor. So now you understand, number one thing about the pleomorphic xanthoastrocytoma, that the tumor is present in the temporal lobe. This tumor is composed of the astrocytes, which are bizarre in pattern, filled with the lipids. And if you look into this tumor, this will show the neuronal and the glial, both the markers. And if I take one tumor cell out, and if you look into the tumor cell, you will see the nucleus, and the nucleus is very much atypical. Then you said, okay, the tumor cells are having the nucleus which is very much atypical, so this is a quality of the high grade astrocytoma. हाई ग्रेड ट्यूमर्स में ही न्यूक्लियर एटिपिया मिलती है ना. सो नाउ यू आर कंफ्यूज्ड कि ये प्लियोमॉर्फिक एस्ट्रोसाइटोमा है या फिर दूसरा हाई ग्रेड एस्ट्रोसाइटोमा है, दैट इज द ग्लायोब्लास्टोमा. सो देर आर द डिफरेंशिएटिंग पॉइंट्स. इफ यूर हाई ग्रेड ट्यूमर, if your high grade astrocytoma is showing these four changes, if your high grade astrocytoma is showing these four changes, it is the pleomorphic xanthoastrocytoma. If there is the high grade astrocytoma but there is the absence of these three things, then it is not the pleomorphic xanthoastrocytoma, then it must be the original high grade astrocytoma, that is the glioblastoma, right? Okay, हो गया जी, चलें. Right, it is showing the nuclear atypia, so must be confused with the high grade astrocytoma, but it is usually a low grade tumor, that is the WHO grade 2 tumor. 5-year survival is looking really good, 80%, so prognosis is better in this case. Lastly, in the astrocytomas comes the brainstem glioma. It is also a subgroup of the astrocytoma, occurs in the first 2 decades of the life, 0 से लेके 20 साल की उम्र तक. और इसके अलावा इसकी भी मुख्तलिफ टाइप्स होती हैं बेटा ब्रेन स्टेम ग्लायोमा की. वन इज़ द इंट्रिंसिक पोंटीन ग्लायोमा विच इज़ द मोस्ट कॉमन टाइप. इसका काफ़ी अग्रेसिव कोर्स होता है और सर्वाइवल बड़ा कम होता है पेशेंट का. देन कम्स द सर्वाइको मेडुलरी जंक्शन ट्यूमर्स दैट अराइज फ्रॉम द जंक्शन बिटवीन द मेडुला एंड द सर्वाइकल वर्टिब्रा. These tumors are less aggressive in course compared to this variety, but they are exophytic, out pouching होती हैं, इनकी आउट ग्रोथ होती है. एंड देन नंबर 3 इज द डॉर्सली एक्सोफिटिक ग्लायोमा. ये तो सबसे बिनाइन कोर्स होता है, मतलब टॉप टू भैया डिसेंडिंग ऑर्डर में सबसे ज़्यादा खतरनाक ये है, फिर ये, फिर सबसे कम डेंजरस जो वैरायटी है वो ये वाली वैरायटी है. ठीक है, दे अराइज इन द टेक्टम ऑफ द मिड ब्रेन पोन्स और उससे नीचे मेडल्ला में से. ठीक है जी, इस तरीके से. What is the underlying mutations that is responsible for the development of this brainstem glioma? It is mentioned here. It is the lysine to methionine mutation at position 27 in the histone protein. It is actually the epigenetic modification in which what happens, the histone पे जो कार्बन 27 होता है उस पे लाइसिन टू मिथ्योनिन म्यूटेशन होती है. If you just keep in your mind this only thing, that is the lysine to methionine mutation in the histone protein, it is enough. ठीक है बेटा, this is all about the astrocytoma. उम्मीद है इसको मैंने ज़्यादा कॉम्प्लिकेट नहीं किया होगा. Then we'll be talking about the another glioma, that is the oligodendroglioma.